all of you for joining in time. We are very excited to have you. This is the first week of our sessions, our 11 sessions, and today we are going to look at symptom management in palliative care and looking at some specific symptoms. So my name is Mackuline Atieno. I'm the Executive Director of the Kenya Hospices and Palliative Care Association, one of the host teams for this course. So we are very happy to have you around. And wherever you are, whether it's morning or afternoon or evening, hope you have taken some water and you are geared and ready for the next 1.5 hours. We really have very good speakers. We have good content, and we are happy that we have all of you here to share even your experiences and to learn from each other. And we hope that by the end of this session, we'll be more knowledgeable on how to manage symptoms, the physical symptoms in the patients whom we see in our different settings. So today we were supposed to have 3 presenters, but we'll have 2. So one of our presenters called Vicky Opio is not able to join because of an unavoidable circumstance. So we have 2 session presenters. So we have Dr. Maha and Ms. Erin does. So the first presentation will be given by Dr. Maha and Erin, who will present on the, Dr. Maha will present on nausea and, Erin will present on nausea and vomiting, and then Dr. Maha will do dyspnea. Then after that, we'll go into a case study. So we'll start from Erin. I'd like to introduce Erin. I'm sure she's not, she's a person you've seen and you're part of the session. But today being a presenter, so we'll allow me to introduce her once again. So Erin is a palliative care nurse from Canada, and she has lived in several countries and supported a palliative care program in the different regions. And currently she's based in Kenya for the last 3 years. And she has been working with KEHPCA and Palliative in a variety of leadership and educational initiatives. So we are happy to have you, Erin, today to share with us on the topic and just share your knowledge with the team. And so you'll be the first presenter. Then after Erin, then we'll have Dr. Maha Kassem, who is a palliative care physician in Lebanon, and she works in Clemenceau Medical Center and Sanad Hospice in Lebanon. She teaches at Beirut Arab University in Lebanon as well. She's also an active member of the Palliative and works to support an education working group. So as you see, today's 2 presenters are people who are global. They have worked in different countries and come in with a wealth of information and a wealth of knowledge and experience on the topic on symptom management. Just before Erin starts, I just want to mention that symptom management, the physical symptom management, is one of the most dynamic aspects of patient care, because people come with different symptoms and the body systems are usually intertwined. So someone can have a symptom in a different system, digestive system, and the different other systems. So the management is usually holistic. The same way we talk about holistic management of a patient by using a multidisciplinary team. When it comes to symptom management, we also looked at the person and look at the holistic aspect there, the body system, how they work, and not necessarily as symptoms. So I'll also request, just as we've always done, that you can turn your camera on, but let's put off our audio so that only the person presenting is able to be heard. And today we'll have a poll in between. We may not have breakout sessions, but we'll have a poll, so it will give us an opportunity to have a lot of discussion. So please feel free to chat if you have any question, even as the session is continuing. Please write on the chat. Each session we can ask the questions and continue. So just remember to put in the chat. And if you have any question during the presentation by Erin or Dr. Maha, just put it in and I'll be able to bring it up and for us to respond to them. So after those 2 presentations, then we'll have a case study on the same, and then we'll continue with the question and answer. So welcome, Erin, and all the best to all of us. Thank you.
Hi, everyone. It's great to have you here today as we focus on a new topic in palliative care that you may not have had a chance to specifically focus on. Today, we're going to be focusing on symptom management in palliative care, specifically nausea, vomiting, and dyspnea, which is a sensation of shortness of breath. So some of these topics may be new to you today. But I want you to grab your book, grab a pen, so you can make some notes, and we will try to answer the questions that you have. If you do have questions during the program, please don't hesitate to put them in the chat. We have several of our faculty members on the call today, and they can answer as we are presenting the lecture. So to start off, nausea and vomiting is actually extremely common in palliative care, and we find it in about 50% of our patients. The common causes of nausea and vomiting in palliative care or patients with palliative care needs are related to medication. So last week we learned about opioids and morphine specifically, but medications can actually cause the symptom or the side effect of nausea and vomiting, including the opioids, the NSAIDs, and antibiotics. Other reasons for nausea and vomiting include metabolic. So this could be issues with hypercalcemia, or if your patient has liver or kidney disease, you may notice that they also present with symptoms of nausea and vomiting. Some of our patients may present with gastrointestinal issues, including gastric stasis. Some may have ulcers or even bowel obstruction. And these are quite common causes of the nausea and vomiting that our patients report. Sometimes we can have patients with central nervous system involvement and they can experience nausea and vomiting, or vestibular causes. But what often occurs for our patients is actually a combination of all of the above. So sometimes it's not just one thing that can cause the symptom, but it could be a combination of things. So it's really important as we start the lecture today that you assess your patients carefully. When they experience and share with you, or maybe their family member shares with you that they're experiencing nausea and vomiting at home, or you notice it or you witness it in the hospital, it's really important that you assess. We only recommend in palliative care that we do investigations if it's going to change the way we manage the patient. We know that many of our patients and families often are experiencing chronic illness. So they have oftentimes have been in the healthcare system for quite some time, and investigations can be quite costly. So we want to make sure we do our assessment first and we assess well so that we can determine if an investigation is truly necessary based on if it will change the way we manage the patient and their symptoms. So here's a picture and an example of a healthcare worker that's doing an assessment and is being very thorough in the way they assess this patient. So this here is a patient with cancer of the esophagus who's being cared by the MSF Palliative Care Program in Dagahali, which is part of the Dadaab refugee camp in Kenya. This picture was taken in 2019. And here you can see that the patient, the healthcare worker is at the patient's level. Looks like they're a team of healthcare workers. One is documenting, one is assessing. When patients have advanced cancer like esophageal cancer, they can experience nausea and vomiting. So that would definitely be one of the questions they would ask the patient and their caregiver about how they're managing with those symptoms. So I want you to think of this patient as we go through the rest of the presentation today. So when we think of managing nausea, we need to correct the underlying causes if possible and appropriate. So for example, if the patient has issues with their calcium levels or they are presenting with an obstruction in their bowels, it's really important that we correct any underlying causes. Because if we don't focus on that, if it's possible to correct those causes, the patient will continue with nausea despite being medicated. We can adjust their other medications. It's really important when we do a palliative care assessment that we identify what medications our patients are on. And if it's possible, we could adjust some of those So we were talking earlier about medications causing nausea and vomiting. That would be the opioids or the NSAIDs or antibiotics. So if it's possible to switch those or adjust them, then we would want to do that. It's really important as a healthcare provider in a humanitarian setting that we actually, and within all palliative care settings, that we regularly administer antiemetics rather than giving them as SOS or only as needed. It's important when we think about this, that we're providing the patient with overall support for their nausea and not just giving it when they feel nauseous, because then oftentimes it's too late and our patients will vomit. It's important when you are trying to determine which kind of medication to give that you determine the best route to give it. If a patient is nauseous or vomiting excessively, possibly the oral route isn't the best option. So if you are able to give medications subcutaneously, if you're able to give a medication even IV, if they have the IV access, these oftentimes will be better routes to give than an oral route if the patient is actively vomiting. We need to remember to prevent and treat constipation. If a patient is constipated, oftentimes they will experience nausea and vomiting. So giving a laxative on a regular basis or making sure that you assess what they're eating, their diet, can be really helpful. Even using a suppository for patients that are severely constipated can help with managing nausea. And then as we think about the environmental setting that our patients are in, whether you do home visits, as we've heard happens in Northern Uganda with some of our participants, or if you are in a hospital-based setting, the best to your ability, try to control the odors around where the patient is lying down or is sitting. This can really help. Also using a cool damp cloth to their forehead, their neck, or their wrist can also provide a lot of relief to the patient experiencing nausea. So as we shift our focus a bit to vomiting, nausea and vomiting obviously are very closely related, but it's important that we think about our treatment being mechanism-based and not just generalized prescription of antiemetics. It's really important that we think about what is causing the symptom, and then we think about what medication can be used to treat that specific symptom. So I'm going to show you right now a bit of a complicated chart, but I have highlighted what I'll speak about in the black writing. So the first part of this chart that I want to talk about is the fact that drugs and the metabolic system can often be a stimulus for vomiting. And that's because in this situation, the chemoreceptor trigger zone has been stimulated. The dopamine receptor has been affected. And when we know these details about a patient who's experiencing vomiting, we can very specifically target this by using medications such as metoclopramide or haloperidol. So as we go through the rest of this chart, I want you to think about your patient or think about that fictitious patient I showed the picture of. And we're going to think about what are the issues that they're facing. As we do our thorough assessment, you will be able to identify what medication to use based on what is being stimulated or what is actually causing the symptom to get worse. For our cancer patients or our advanced cancer patients, sometimes they're on chemotherapy. This chemotherapy can seriously cause severe nausea and vomiting, and the receptor that is targeted for that is serotonin. So oftentimes we use ondansetron or ganisotron if it's available in your region. So those are very good medications to use for patients that have chemotherapy-induced nausea and vomiting. Some of our patients may experience motion-related nausea, and this is stimulated due to the vestibular area. And the receptors that are impacted are the muscarinic and the histamine receptors. And for that, we usually use cyclizine, promethazine, and diphenhydramine. Again, in your region or in your workplace, you may not have access to all of these medications, but hopefully you have at least one that you can use with. The next one is the visceral. So if you have where the visceral or the organs are being stimulated that is causing the nausea, dopamine and serotonin tend to be the receptors for that. And we know specifically we can use metoclopramide on danzatran and haloperidol to target this type of nausea and vomiting. And the final section is the raised intracranial pressure. So if you have a patient that has raised intracranial symptoms, their cerebral cortex is being stimulated and the histamine is the receptor that's being targeted. And for this, we can often treat this type of nausea and vomiting with dexamethasone or cyclizine. So we know as physicians and as nurses, there are many types of medications that can be used to treat nausea and vomiting. We need to just make sure that we choose the right one or it's not going to be effective. So this is a really helpful chart and we will definitely share the slides with you all. So maybe you could even print this out and keep it in your pocket, kind of as a pocket guide to help you prescribe and recommend medications for nausea and vomiting specifically. So again, when we manage nausea and vomiting, we want to treat the cause, if possible and appropriate. You want to anticipate the need of that antiemetic and you give adequate regular doses and combine the medications if necessary. So today we're going to specifically talk about the anti-dopaminergic medications for anti-nausea, and we'll help you give some doses and suggestions for the doses for that. So the first medication we're going to talk about is metoclopramide, and we usually recommend 10 milligrams QID, PO if possible, if not subcutaneous or IV. And again, the receptor that's targeted here is the central dopamine and the serotonin. And we know that this medication has peripheral prokinetic action, and it ends up relieving gastric stasis. The one thing to remember specifically about metoclopramide is that we must avoid it if a patient has been diagnosed or we anticipate that the patient may have bowel obstruction because there is a large risk for perforation of their bowels. Unfortunately, with this medication, patients can have side effects, which often can be difficult for them. And we do need to make sure we reduce the dose if a patient has renal dysfunction. So the extra pyramidal side effects are a risk for these patients who are prescribed metoclopramide. The next medication I want to talk about is domperidone, and we often recommend a starting dose of 10 milligrams PO, TID, or 3 times a day, up to a maximum dose of 30 milligrams in 24 hours. This one is through the peripheral D2 antagonism receptor, and it doesn't cross the blood-brain barrier. So therefore, patients are at less risk for the extrapyramidal side effects. Patients may have a risk for QT prolongation, and we do recommend a reduced dose for renal dysfunction patients. Haloperidol is a recommended dose of 0.5 to 1 milligrams PO or subcutaneous, twice or 3 times a day. And this one has the central dopamine antagonism effect, and it's a really good choice for patients who are experiencing nausea due to a bowel obstruction, which oftentimes our patients with advanced cancer can be at risk for. You do want to avoid this in patients with heart arrhythmias because it can cause that QT prolongation issue. And the last 3 medications that I'll mention today are the prochlorperazine, levomazine, and olanzapine. These end up being broad spectrum medications because they target multiple receptors. And we often use them as second line when we don't often know the cause of the nausea. But they could be really good for anxiety-related causes of nausea. So So hopefully with those ideas and those recommendations for medications, you'll have a really good start on what you can do to help patients. In palliative care, we also try to think of a holistic approach. So we do want to mention the non-pharmacological and nutritional management for nausea and vomiting. So for patients, we can recommend diet modifications if there's certain foods that make the patient feel quite nauseous, then we try to avoid those. We do know that many of our patients, their taste begins to change over time. So this can not be very pleasant for our patients. So in terms of some alternative medicine or complementary therapies, we have had really good effect with using ginger or peppermint, along with lemon tea or cardamom. These are natural or herbal ways to provide some support. It may not give the full effect to stop the nausea and vomiting completely, but can be used in addition to the medications that you would prescribe. So now I'm going to pass it over to Dr. Maha, as she'll talk about the next symptom, which is dyspnea. Welcome.
Hello, everyone. We'll start with dyspnea. We'll start with the definition of dyspnea. Dyspnea is sensation of shortness of breath. Dyspnea is not labored breathing, it's not fast breathing, and not low oxygen saturation. Dyspnea is subjective. Dyspnea is whatever the patient says it is. Dyspnea in palliative care, approximately 50 of the patients referred for palliative care. Up to 70% of lung cancer patients present with dyspnea. More common in last weeks of life, occurs frequently in patients without lung involvement. Dyspnea can be described as air hunger, the need to breathe while being unable to increase ventilation, effort of breathing, physical tiredness associated with breathing, and chest tightness, the feeling of constriction and inability to breathe in and out. Erin, it's the next slide. Thank you. Okay, we'll move to the most common causes of dyspnea in palliative care. The tumors involving of lung tissue or airways, infection like pneumonia, COPD, congestive heart failure, and pulmonary embolism, respiratory muscle weakness, ascites, anemia, and anxiety. We'll move to treatment. We should remember to treat the underlying cause if possible. Like infection, we can use it. You can use antibiotics, and congestive heart failure, some laxatives, and COPD with bronchodilators. In general, pharmacological, oxygen, chemo, radiation, and surgery. And don't forget, please, that we have the concept of total dyspnea like pain. It's multidimensional, including the physical, psychological, and emotional aspects. General measures should be taken. The position, fans, open window, cold air will maintain, and please maintain the COVID-19 rules. Good evidence showed that breathing techniques and training can help decreasing the dyspnea, relaxation techniques, and pacing priority settings. In a living situation, please avoid stuffy rooms with no airflow. For babies and children, position of choice and play therapy showed good evidence to decrease the dyspnea. For pharmacotherapeutic measurements, the medications, yes, opioids start at lower dose than for pain. A clear evidence of use of PO subcutaneous and IV. Same principles as pain management, use the routine, not as needed. Morphine is the first line of treatment. Start with the half dose. You start for pain, 2.5 to 5 milligrams PO in adults every 4 hours and as needed. Increase as required to reduce the dyspnea. Some useful medications can be used, like steroids. Dexamethasone, 48 milligram once daily, can be given in the morning for superior vena cava syndrome, bronchial obstruction, and for radiation pneumonitis too, and carcinomatosis. For benzodiazepines, it's important to assess the patient and treat the anxiety, since we know that the anxiety and dyspnea are so related. If the anxiety is high level, the dyspnea will be increased. So the benzodiazepines showed that it reduces the burden of shortness of breath, with lorazepam low dose with 0.5 milligram to be given twice daily. Thank you.
Thank you, Dr. Maha.
Thank you, Erin.
Yeah, great. We have a bit of time now to review any questions that people may have, or if anybody has a specific other symptom other than nausea and vomiting or dyspnea that they're facing. We can go into a bit of a time of discussion. If you raise your hand, Mackuline will call on you, and then we'll go from there.
So thank you so much, Erin and Dr. Maha for the presentation. So from the chat, I've already seen one question from Rose in Rwanda, who was asking about the mechanism based. What is the mechanism based? So it was during the presentation on nausea and vomiting. Okay, yeah. So Erin has said that in the chat. Maybe you could also just mention it verbally.
Yes, yeah. So nausea and vomiting is I may call on Dr. Megan also to help me out, but it's a complicated symptom. And there's many types of medications we can use to treat the general symptom of nausea and vomiting. But what we try to do in palliative care is to really identify what is causing the specific what is causing the specific symptom, and you can often be able to identify that through your assessment. So when I talk about mechanism, we were talking about in that chart where we talked about chemotherapy, sometimes medications can cause nausea and vomiting. So being able to identify what is the mechanism that's causing the symptom to be able to treat and really use the right medication to treat the symptom. Because not all anti-nausea medications will help relieve nausea and vomiting because the causes are quite different.
Thank you so much, Erin, for that. I've seen another question from Salmo Salah, but before that, there are also some comments, and let me see if there's any that answers the question. So there's a Dr. Andada who is saying that we can use in pediatric cases the bubble technique. We ask the child to blow bubbles. So we'll give you a chance, if it's possible, to just explain how that works. And as I take the question from Muhangi, maybe I would also like to hear from the participants how, in practice, you decide on the medication that is given for nausea. Just in the field, what happens when someone has nausea? Do you look at the course, or you just decide on which medicine is available? So it will be interesting to hear what you do in practice and discuss together how going forth you'll be able to select the medication and intervention according to the session we've had today. So Salam, maybe I can give you a minute for a question, please. Unmute.
Thank you so much. Thank you, Erin, for the presentation. Me, I'm on nausea and vomiting, particularly on dieting. We've seen we are giving ginger, we are giving peppermint, we are giving lemon, and sometimes, okay, there are some patients who have ulcers. Do we really have to continue giving such? Mostly ginger and lemon. And then also, for example, having a lot of nausea and vomiting, actually running an empty stomach. Give us a highlight of how to mix it or something like that, because I'm worried we may be burning onto the walls of the stomach if we give that kind of stuff. Thank you.
I think
I
for
think
nausea and
he's-
vomiting, it does definitely depend on when you see the patient. If they've been nauseous and vomiting for many days, by the time they come into the hospital, of course, they'll be dehydrated, right? So we need to make sure that we're taking into consideration how long they've been nauseous, and if they've been vomiting for many, 24 hours, 48 hours, that will make quite a difference in terms of how you prescribe. I would say anyone with severe nausea and vomiting, we need to treat with medication. So oftentimes that will be intravenous because they won't be able to keep down medication. If you're thinking for a patient where you could do diet modifications, most likely those patients would be at home. I would assume they wouldn't be sick enough to have to come into the hospital. In terms of the diet modifications, it wouldn't often be enough if you had a patient who had severe nausea and vomiting and was dehydrated and quite sick. Does that
Okay,
seem
thank
to
you.
make sense?
Thank you so much
Awesome.
for that. We have a response from Megan, who's saying that if you're unsure of the cause of the nausea and vomiting, then it will be safer to use a dopamine receptor antagonist as this medication, especially if you are not sure or if you're not able to do proper assessment. But I'm still waiting to hear from you about how we do it in practice. And then also, there's another comment that for a patient who has ulcers or stomach irritation, which is, I think, one of the issues this Salam has provided, he said that you can provide an anti-acid medication like an H2 receptor blocker or proton pump inhibitors to support that. Are there other questions on nausea and vomiting? Because some of the comments which I'm having are linking on other symptoms that people are interested in. So Megan, I'm still dwelling on nausea and vomiting and dyspnea, and then you can go to other symptoms and then experiences. Yes, Megan.
Yeah, I think it can be a little bit confusing because there's so many medications you can choose from. So an easy way to think of it is, like I said in the comment, usually first, if you're not totally sure why the patient's nauseous and it's not from chemo, for chemo, always go to ondansetron, granisetron because of the receptor, but otherwise go for dopamine receptor antagonists. So that's why I recommend whatever you have, but metoclopramide or haloperidol are the most common ones that are easily available and at low doses have very minimal side effects. So that's why I just think that's a good way to sort of think about your starting mechanism for patients who need palliative care.
Yeah, thank you so much, Megan, for that advice. I think it's very, very useful, and especially for people in chemotherapy, because that one, at least we have an option to start with. I'd like to, is there anyone who would like to share? What they do? As I wait for a hand, this is another comment about from Elizabeth, who mentions that I come across children with mucositis and ulcers, which means we feed them on through the nasogastric tube, and however they still vomit. So the drug of choice is still ondansetron. So he's asking, are there any other options which can help such children, especially the non-pharmacological options for children with mucositis and ulcers who are feeding through nasogastric tube?
Is that like children? Are we talking about children with cancer?
Yes.
Oh, okay.
Yes. I assume yes.
Yeah, that's what I was assuming there. Yeah, ondansetron's good, but so the thing with nausea is that if you layer multiple medications which have different receptors, you get better anti-nausea effect. So if you give ondansetron and it helps a little bit, but they're still nauseous, then a good strategy is add another medicine from a different category, like haloperidol or metoclopramide or domperidone, or if you have antihistamines like cyclizine or diphenhydramine. If you combine three that work in different ways, you get better anti-nausea effect. So that might be the strategy for the child there.
Thank you so much, Megan. Okay, thank you so much. So there's another question still on nausea. How can we identify nausea in preterm neonates? And which drug is best for the neonates?
Neonates are tricky. I would say overall, they're not usually very nauseous. Remember, babies vomit because they have dysfunction of their lower esophageal sphincter and so whatever's in their stomach comes back up. It doesn't usually mean they're nauseous. So you don't always have to treat that unless they seem really upset. I would not worry that most neonates are nauseous. I would say I have not seen a lot of neonates with profound nausea. If you really think they're nauseous, then you could try ondansetron, or you could try antihistamines like cyclizine or something else in that category. Like if they're getting chemotherapy, I guess.
Okay, thank you. I can see another question from Salam, and I will encourage us to please let's participate. If you have any question, or if you'd like to share your experience, it's very, very important. And in the next few minutes, then we'll go to other symptoms that we'd be interested in. So there's a submission by Susan who says that in Thailand, where marijuana is legal, it's highly effective in supporting nausea and vomiting. So I don't know, Susan, if you have a minute, maybe you can explain that and how it's used in Thailand. If it's okay, you can put it in the chat, or you can unmute and just give us.
Hi, good morning and good afternoon to everyone in your time zones. Yes, in Thailand, it's now become legal, and they have medical marijuana clinics with trained physicians, and it's standardized. So it's ganja oil, and they start the patient off for pain management, nausea, all kinds of symptoms, for appetite, to help with appetite. And it's been highly successful, very effective, and very inexpensive, and easy to administer because it's sublingual. So it's just a few drops under the tongue as tolerated. It also helps with sleep, all kinds of symptoms, anxiety. It's actually been really amazing. And they're continuing to do studies around it and the effectiveness of it. And yeah, with great success.
Oh, thank you. That's great, especially for countries
It's a
of people
very
who are
inexpensive way to meet these needs. And the skeptics have now really seemed to come on board and go, yeah, this is great. And, you know, you can use traditional medicine as well, but it's been very effective and, of course, invasive and doesn't have bad side effects usually. So quite helpful.
Okay, thank you so much. Salah, you have another question?
Oh, no, it's just a contribution. Thank you so much, Doctor. It's just a contribution on how to manage nausea and vomiting in neonates. In my experience, I've already seen us do abdominal lavage with saline water, and also you put a line on a child, and the child is given, or the baby or the neonate is given antibiotics at least for the first 3 days, 3 to 5 days. The treatment that is usually given could be amoxicillin or gentamicin, depending on the doctor. And they actually pull out. I mean ampicillin, not amoxicillin, ampicillin IV for the first 3 days. And I've seen them pull out. Usually it's kind of an infection they may have gotten, maybe they swallowed during childbirth. So an abdominal lavage really works a lot. Thank you.
Thank you. And maybe if you could add, how do you identify nausea in neonates? For you maybe to give the lavage, is there any things you look out for?
Yeah. Usually these children will be, I don't know, is it like a hiccup, but they kind of they show that they are really wanting to throw out. Like every time they want to vomit and they try to vomit, when they vomit, there are some abdominal substance that comes out, which is kind of brownish, and you know, with abdominal content is always, it gives that kind of color because of the hydrochloric acid in the stomach. So usually you'll get to know that the child is either having nausea or they are vomiting with that kind of little
Okay, thank you so much. There's Erin, maybe I can let you unmute. There's a comment which you put there on bang roll death. Please just clarify.
Yeah, I
on
think,
fluid
I mean,
replacement.
yeah, I think sometimes when we talk about fluid replacement, if we are remembering that this course is focusing on palliative care patients, there is oftentimes a dilemma when we talk to our palliative care patients or end of life patients about providing fluid replacement. For patients that are severely, are quite symptomatic due to the nausea and vomiting, we tend to actually not see this at the very end of life when it becomes difficult for us to explain to families that we can or cannot provide fluid replacement. So I think sometimes these questions are really good, but it's hard to give generalized answers on fluid replacement or that sort of thing, because each situation of a patient is quite different. If a patient came in, you know, and they were vomiting and it seemed like it was a very good idea to replace their fluids through IV therapy to stabilize the patient, I think that wouldn't be a problem. If the patient was quite end of life and didn't have severe nausea and vomiting, we often don't recommend it because it can be very difficult for the families and doesn't end up improving patients' quality of life to give IV fluid at that time. So yeah, I think each case is different, but I think it is really important to treat the nausea and vomiting as best as we can through medication, and then replacing fluids as necessary.
Okay, thank you so much. We still have a case study to go through. So maybe if you allow me, I'll close on the topic of nausea and vomiting. Then if there are any questions, maybe for 1 minute on dyspnea, please, we can ask, and then we'll move to the case study, which may answer some of the questions that we have, if you allow me. So I'll just give 1 or 2 minutes for questions under dyspnea, and then we'll go to Erin for the case study. Yes, Jim, I'll just give 2 people, Jim and 1 more person, and then we'll proceed.
I'm
Okay.
sorry, I'm still inquiring about the vomiting in neonate. Could do a passing an NG tube possibly help maybe prevent aspiration? And then if it's okay, how long do we keep this NG tube in? Nasogastric tube. Thank you.
Okay, thank you, Jim. So those are 2 questions. Cannot nasogastric tube prevent aspiration? And how long should we keep the nasogastric tube in for a unit?
I mean, that would
I
not
would like
be
to answer.
standard management unless you think there's an obstruction. You know, like the babies should protect their airways. If they vomit, it's fine. You don't put an NG tube in to prevent aspiration unless it's a premature baby. But I don't think we're talking about palliative care patients here. I think that what your question is a bit broader. I don't think it's really focused on children who have palliative care diagnoses. So we can't speak to the management of every neonate who vomits. Okay, this course is just focused on children with life-threatening and life-limiting conditions, you know, with cancer, with like severe congenital malformation. So I think the question's getting a bit off topic for us today.
Okay, thank you so much. But if anyone has an answer, maybe you can put in the chat as we continue. So I'll welcome Erin to go through the case study, and if time allows, at the end we'll be able to address other questions. Thank you, Erin. Over to you.
And don't forget to put any questions about the dyspnea in the chat. I think nausea and vomiting is a very complicated symptom to manage, but dyspnea is as well. So if you have any questions specifically about that, we'll get into the case discussion now. Sorry, the case presentation, and hopefully that will help us with the dyspnea. The case discussion is on dyspnea, which is great. So let me just share my screen. Sorry, guys. Okay, so for the presentation today, I want you to again think of this patient. He is a 57-year-old man with chronic obstructive pulmonary disease, which we call COPD. He also has hypertension and diabetes. He lives in northern Uganda as a refugee with his wife and his 2 sons, who are aged 12 and 14. He was a former day laborer, but he hasn't been able to work for several months due to the worsening of his COPD. You do a visit with him at home. So I want you to think of what are some questions you would ask him about his symptoms. So we can begin to put this in the chat. We will follow up with these questions in our small group breakout rooms, but we'll take 1 minute now. If you can just write in the chat, what are some questions that you would ask this man who's 57 years old about his symptoms at home? So think about assessing a patient who has COPD. What are some questions you would ask him about how he is feeling?
There's a question on any history of easy fatigability and breathlessness.
Perfect. Yeah, so what makes him tired? What makes him fatigued? What makes him breathless?
Current medication he's using to manage the symptoms.
Perfect. So to get an idea of what his background, has he been treating his COPD? Has he been managing his chronic illness?
If he can keep up with peers on walking level ground, that's a good one. On exercise, about shortness of breath and the medications he's using, as you've mentioned.
Yeah, perfect.
These are some of the questions. Yeah.
Yeah, really good. We want to know what how can he function? Is he functioning well? Is he managing? Perfect. I see a lot of things coming in the chat. Can he use stairs in his house? Does he have a history of shortness of breath? Is he experiencing any pain? Perfect. These are all really, really good symptoms. As we begin to assess our patients with palliative care needs, we need to continue to learn how to ask them questions well, get a medical history. I like that one, history of TB in the family. That's a really good one. What happens when he's lying down or standing up? Another really good one, what makes his symptoms worse and what relieves them? So what helps with his breathlessness or dyspnea and what makes it worse? Triggers, perfect. You guys are getting this. This is really good. Keep thinking this way. Okay, so as we move on, he reports dyspnea, fatigue, and anxiety. So he rates his dyspnea as a 4 out of 10 at total rest, but when he does activity, which is one of those questions that you guys said that you would ask, he rates his dyspnea as an 8 out of 10. He shares that his fatigue level is about a 4 out of 10, and his anxiety is 2 out of 10, except sometimes at night, it increases up to 6 out of 10. His dyspnea, or his shortness of breath, improves with bronchodilators, airflow, which Dr. Maha was explaining earlier by opening the window or using a fan, and oxygen. So as we get a little bit more information, as we're in the home visit and we're asking these really good questions that you guys have mentioned in the chat, and we're getting a good report of what his status is, what might be your next steps? So we can take again another 1 or 2 minutes. We'll go over more details of this case in our breakout rooms, but what might be your next steps for this patient? You can put it in the chat. What would you do next? So it seems like for this patient, an 8 out of 10 is definitely a symptom we would not want to just leave his house with. So what could we do to support him with his dyspnea? So we could investigate heart failure. So this is a home visit for a palliative care patient with COPD, but we could investigate for that. It may be a little bit difficult in a camp setting or humanitarian setting, but it is possible. You can confirm from the patient, maybe the doctor didn't change his treatments. Yeah, so we could confirm what is happening with their current treatments. For the anxiety at night, really good. Encourage the patient to sleep in a propped up position, really good. So we can help and change their environment, maybe by using some pillows. I think the anxiety could be causing worse shortness of breath, so propping them up at night and repositioning would be good. Yeah, I like Anne's comment. We can ask what's happening in the evening that's causing the increased anxiety. So he didn't specifically say that the dyspnea or the shortness of breath is causing the anxiety. So we should definitely ask about that. So here it says, put the patient on oxygen for support. Is it possible in your settings, feel free to answer in the chat if you can, is it possible to get oxygen at home for this patient, or is oxygen only able to be given in a healthcare facility? Other good steps, bronchodilator, steroids, breathing techniques, really good. Someone suggests to admit the patient and monitor them. So that's a possibility. Someone suggesting using less strenuous activity, good point. We don't want the patient to be doing strenuous activity if they're quite short of breath. We could check for their oxygen. We can do mindfulness exercises, really good. Check vital signs. Okay, someone is suggesting prescribe haloperidol to manage dyspnea. All right. Okay, we're going to move on to the next one. For this patient, an option to manage their dyspnea is to manage their disease. So that would be specific management or targeted management of the COPD. The way that we treat shortness of breath, is it different for of dyspnea for someone who has malignancy or an advanced cancer, or for someone who has heart failure? We can offer oxygen, the airflow using a fan or a hand fan. And then we did talk about this earlier when Dr. Maha was presenting of symptom-directed therapies, including opioids. So for this patient, I want you to think about how we might start opioids on this patient. Would you do it in as needed? Would it be a scheduled dose? Would you give it in advance of an activity? And then how would you explain to the patient that they would be starting on opioids and what the side effects are? This will take into account the information that we learned last week, and the information that Dr. Maha just recently taught us about opioid use for dyspnea. So we are going to shortly go into our breakout rooms, and we're going to take some time to do that and discuss as a team. One successful strategy for this man who's experiencing dyspnea is to offer oxygen 2 to 6 liters per minute by nasal cannula, again, if it's available. I assume, again, like someone mentioned, probably they would need to be admitted for oxygen support. We would recommend continuing with the patient's bronchodilators as the main treatment for his COPD. We would encourage the fan, and we would recommend the starting of morphine 2.5, which is a low dose, PO every 4 hours as needed for this patient. There is some new research out in August of 2020 that showed an effective use of sustained release morphine for COPD. So we also do need to remember that we can look to research. We can make sure that we are up and aware of what the latest research is, and make sure that we are supporting patients in this way. So I'm just going to take a minute now. We're going to do a poll. We're going to do a quiz, and then we're going to go into our breakout rooms for the last half an hour. So you'll see a poll pop up. Oh, no, it's not there. Okay, never mind. We won't do the poll. We'll do our breakout rooms. And thanks to the faculty who have joined us today, we'll just get us started for that. So let me just create the breakout rooms now. If you have, again, any questions about dyspnea, then please don't hesitate to put it in the chat. So we'll continue in the breakout rooms to discuss this case of this patient who has dyspnea. And David, Mackuline, Ruth, and Dr. Maha, I'll get you to lead those breakout rooms. There's about 20 people in your rooms. So I'm going to open them now, and I'll share the questions, but just to have a continued conversation about the dyspnea symptom and how best we can treat dyspnea with our palliative care patients. So you're welcome for that. We will do the breakout rooms for the next 25 minutes, and then we'll come back together. All right, thanks everyone.
Hasta mejor de saber. Ya
So we'll just wait for everyone to rejoin us. We just have about 5 more minutes left. And hopefully Mackuline can end us on the call today. Ruth,
Thank
did
you
you
so
want to?
much.
Yeah, go ahead, Mackuline.
Thank you so much for attending the session. I hope the breakout sessions have been very useful. From my group, we briefly discussed the session, but then we geared towards generally discussing dyspnea and looking at the non-pharmacological aspects, the use of morphine in other aspects, and also sharing our experiences from on how we manage dyspnea in our settings. So it was quite a good one, and I hope the other breakout sessions also had good feedback. If we had time, we would have allowed each group to share, but we have about 3 minutes to go. So from the faculty, I don't know if Erin or Dr. Maha, you have a comment? Or Erin, there's someone you wanted to comment before we close?
Yeah, maybe Dr. Maha can share just some final comments
Yes.
from her group. That would be nice.
Okay, we discussed, they were actually my group, they were concerned about the double effect of opioid on the dyspnea. So we ensured them that when using opioid in appropriate way and in a small dose of smaller doses of pain management, so the dyspnea will be decreased and it won't affect the respiration for the patient. We discussed about the non-pharmacological aspects too, about his anxiety, how to relieve his symptoms and to improve his quality of life.
Okay, thank you. So maybe I can just allow the other group to just do that for 1 minute so that we hear from each other. That's allowed. So the group from David, maybe just a summary of what you discussed.
Yes, just a quick one that the group admitted and acknowledged that the patient has many comorbidities, and so therefore the proper assessment would be very key, and the many symptoms that the patient has, we need to be mindful of that as we manage them. Issues around bill burden, depending on the symptoms that we want to manage. And again, from a humanitarian setting, and being an elderly man with 2 teenagers, so psychological aspects and care and support for those teenagers is equally important. And then the whole aspect of which medicine to use vis-a-vis the worsening COPD situations. So again, being mindful of that. So it was a rich discussion. Thank you for the opportunity.
Thank you so much, David. Any other group from Ruth's group? Just for a minute, maybe add in what the other groups have not mentioned.
Well, we rather concentrated on the non-pharmacological aspects, so how we could support the family and the patient with both physically, sitting up and positioning, and the more on the nursing side perhaps, but also on how patients can be supported with some counselling and spiritual, meeting their spiritual needs, and how we might enter into these sort of dialogues and conversations. And I see that's the topic for next week as well, looking at communication skills. So it was a good entrance into it.
Yes. Thank you so much, Ruth. I think I've not left any other group because I'd like to close. It's time. Is there any group that I've left out? No. Yes.
We were group 5. Actually, they didn't have a faculty member for half the session, so I think they were kind of muddling their way through. But thank you. Sorry, group 5, about that technical issue. But yeah, we were talking about how to assess for dyspnea, not necessarily in that COPD patient, but what are some of the things we can do to make sure we have a good assessment. And then there was a question about using morphine for asthma patients. So just talking more about low dose morphine for dyspnea for our palliative patients with life-threatening illnesses. So unfortunately, Melinda in our group shared that in her workplace, she only has access to 10 milligram tablets of morphine. So doing a low dose might be a challenge for her, but yeah, she did appreciate that.
So thank you so much. Thank you so much for your participation. We really appreciate it. We had a lot of learning. And because we have the chat, the WhatsApp group, so if you have any linkages, if you have any questions, we can continue with the chat during the week as we wait for the next week session, which has been put on the chat. So I wish you a good rest of the day, rest of the morning, all the best, and God willing, let's meet on Tuesday. Bye, and thank you so much.
Bye, everyone.
Thanks, everyone. Thanks for coming out today.
Yeah, and yeah.
Bye.
Thank you for facilitating.
Thank you.
Bye.
Bye.
Thank
Thank
you.
you.
Bye.
Bye. Thank you, everyone. Bye.
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 Have a good day, please. Have a good day.
Bye. See you next time.
Adiós, Cuyo.
Bye. See you next.
Anka. Tiko kutuletea.
Thank you. Bye bye.
Bye bye.
Thank you. Bye bye. Bye bye. Thank you so much.
Eating agora.
Bye, everyone. If any of the faculty can stay on just for a minute, that would be great.
Cuma bolja. Cuma bolja guys. Bolja cai rotan. Neighbor.